Good day, ladies and gentlemen, and welcome to the Financing Medicaid webinar. All lines have been placed on listen-only mode, and the floor will be open for questions and comments following the presentation. If you should require assistance throughout the conference, please press *0 on your telephone keypad to reach a live operator. And at this time, it's my pleasure to turn the floor over to your host, Lisa Waugh. Ma'am, the floor is yours.
Thank you, and good afternoon, everyone. I'm Lisa Waugh. I'm a program director with the NCSL Health Program. On behalf of the National Conference of State Legislatures, I'd like to welcome you to today's webinar entitled Financing Medicaid, Running the Numbers Based on 2017's Policy Proposals. I'd like to remind participants that NCSL is a bipartisan membership organization of state legislatures. NCSL advocates for the interest of states and provides policymakers with an opportunity to exchange ideas. This webinar is a platform for information exchange, and we encourage a robust Q&A at the conclusion of the presentations. We remind participants that they can ask questions at any time during the webinar. Please enter your questions in the Q&A box at the bottom left-hand side of the screen and specify which speaker you're addressing your questions to. I'll read the question and ask the speaker to answer. Also, today's webinar will be recorded and will be available on the NCSL website by next week as a video archive. Our first speaker today will be Rachel Bevins-Morgan, who will provide an update on congressional activities related to the proposed repeal and replace legislation. Rachel is from the Health Policy Program at NCSL's DC office. The next presenters will be Martha Heberlein and Chris Park, principal analysts from MACPAC, which is the Medicaid and CHIP Payment and Access Commission, a nonpartisan federal legislative branch agency. Martha and Chris will provide an overview of proposed Medicaid block grants and per capita caps. And finally, we'll hear from several legislators who will share brief comments on the implications for their state programs and budgets. Representative David Heaton is on the line from Iowa, and Representative Robin Gable from Illinois is also on the line. Representative Joni Jenkins from Kentucky may be joining us later. The legislators will be available to answer your questions at the Q&A session at the end of the webinar. So, Rachel, I'll turn things over to you now.
All right, thank you. Good afternoon, everyone. I just want to make a quick note before I get started on the slideshow that there was some significant action yesterday. President Trump's nominee to serve as the administrator for the Center for Medicare and Medicaid Services, Seema Verma, actually received approval from the Senate Finance Committee, who voted 13-12 to advance her nomination to the full Senate. We do expect her to be confirmed, and we will be, NCSL that is, will be reaching out to her and CMS to arrange an opportunity in the future for us to have a webinar with her involved, so they will be able to have some kind of dialogue with her. Our goal today here, I want to point out, is that we're hoping to discuss and bring some insight to you on some of the prevailing financing models that are being discussed up on the Hill. And throughout the last 2 or 3 years, there have been several blueprint documents produced by Republican leaders that have given us some ideas of where they are moving in terms of proposals for financing the program. So let's talk Medicaid a little bit now. I figure that to understand what the program funding where it might be going, it's good to start with an understanding of how the program is actually financed currently. I'm going to get this. There we go. Federal law currently requires state Medicaid programs to provide services to a defined mandatory population that includes income-eligible families, pregnant women, and children through the ages of 18 whose income is at or below 133% of the FPL. It also provides for income-eligible individuals who are over the age of 65 and blind or disabled who qualify for SSI, individuals who age out of the foster care program up to the age of 26 if they don't qualify for other types of coverage, and income-eligible groups of legal permanent resident immigrants. States also have an option to pick up optional eligibility groups and then also to provide for varying services. They can apply for waivers through CMS to offer those services. The Affordable Care Act was enacted in 2010 and created a new mandatory Medicaid eligibility group that covered all adults under 65 if they had an income up to 138% of the FPL. Initially, the expansion was to be implemented in all states, or the state would potentially lose their federal funding for their Medicaid programs. This led to a number of claims filed in court, which ultimately led to a Supreme Court ruling in the case of the National Federation of Independent Businesses, NFIB versus Sebelius. In this case, the court ruled that the state may not lose federal funding for its existing program if it doesn't implement the Medicaid eligibility expansion under the ACA. There are about 31 states now in the District of Columbia who've chosen to expand their programs, and federal financial support for that expanded population provided a 100% matching rate to the states for 3 years and then would phase down to 90% by 2020. I believe I skipped one here just a minute. Here I've provided a slide that shows you the federal and state actuarial projections for Medicaid expenditures as it is structured today. This report was put together by CMS and actually published in December of 2016. Over the last 3 years, 2 funding scenarios have emerged as the more popular alternative mechanisms among the Republican leadership, as I mentioned before. And the congressional majority and minority staff that we've had an opportunity to speak to have told us that pretty much block grants and or a per capita cap model of financing has been the most discussed options among the majority proposals. This table provides a comparison of the current structure and some of the base analysis and information on the 2 alternative funding mechanisms. The House Republicans have now published a brief, I believe it was February 15th actually that it came out, and it was broadly discussed on the 16th. And to this point, they have not actually published or introduced legislation, but this is the framework upon which they're building that legislation that they will be introducing. There was, a couple of weeks ago, a legislative package that was actually leaked that's caused kind of a fervor in the news, and it's been quite interesting. There's been a lot of comments and a lot of attempts by various individuals in the Senate, I understand, who've tried to get copies, official copies of the legislation, but have been unsuccessful at doing that. But our discussions today are going to be based strictly on this policy brief because we're not sure at this point in time whether the language that was leaked through this copy will ultimately be introduced up on the Hill or not. Here we go. The brief outlines a proposal to provide each state a Medicaid allotment based on its federal matching rate. I believe I'm not sure I'm on the right slide here. All right, first I'd like to talk about the impacts on the expansion population. The proposal document, which incorporates many concepts from a blueprint document that was actually published late last fall, came out of a task force that the Republican leadership put together in the summer of 2016. And it lays out specific goals of their plan that the repeal and replace legislation hopes to achieve. It offers proposals for the private insurance market as well as Medicaid. It would repeal the ACA Medicaid expansion in its current form, but continue to provide enhanced funding to the expansion states for a specific period of time, but it doesn't define what that means. That should be forthcoming in actual legislative language. But then it would revert back to a traditional federal match at some given point. No specific dates are provided in the language, as I said, and it also offers a non-expansion state some additional funding temporarily to support transitional activities based on whatever the language actually, how it structures the Medicaid program. It also proposes to offer states additional flexibility to alter their plan design in their programs, but very few details are provided. The brief outlines a proposal to provide each state the Medicaid allotment based on its federal matching rate. And the allotment would be the product of multiplying the mandatory populations by the number of enrollees in each group and taking into consideration each state's average Medicaid spending. Certain federal payments would be excluded from this calculation, and that being, they specifically stated, dish payments and matching rates for administrative costs. But there may be others. I'm trying to get the thing to advance. It's not advancing for me. There we go. It also, let's see, the states would be given a choice to receive federal funding in the form of either a block grant or a global waiver. Their calculations would also assume that the states would transition existing expansion populations into other forms of health coverage. And either way, a state would still be required to meet basic federal service requirements for their programs. It also repeals the ACA dish payment reductions that supported critical access hospitals, particularly those in rural areas. And then it offers state innovation grants. I thought I'd also point this out because I think that the impression that I have is part of what they're going for here. This funding could potentially impact some of the expansion population that would be transitioned out of, or could potentially be transitioned out of the Medicaid program into other forms of coverage. And it would make it more possible or allow states to use some of that funding for premium subsidies or those high-risk, high-needs populations that were part of that expansion population. So, and I've listed out a number of things that they listed in the brief where the funding could be used. As I mentioned earlier, there was a leaked draft of some legislation, and there have been so many comments made in the press by Republican legislators who voiced concerns based on what they saw in that language. So, I mean, it's very clear based on some of these comments that the majority is far from reaching consensus at this point. In fact, there definitely have been 3 senators who have said, Republican senators who've said that they could not support what they've seen at this point. So there's still a lot of negotiation that has to be done moving forward from the majority side. We've reached out to minority staff on the Hill to find out as much as we can from the Democrats' perspective, and we've been told that there are great concerns about proposals to cut funding on the state Medicaid programs by either repealing or scaling back the expansion and block granting or per capita capping the program either way. There has been one piece of legislation introduced by Representative John Lewis from Georgia, who introduced a measure in January. It's H.R. 335, the Medicaid Expansion Parity Act of 2017, and it would provide an enhanced FMAP to every state that expands the Medicaid coverage regardless of when the expansion actually took place, so providing some protection for those states. And moving forward, we'll be just monitoring as much as we can any packages, and from what we understand, the hope was to be able to have some legislative package actually introduced by the middle to the end of March. Whether that happens or not, that's the big question. With all of the comments in the press from various Republican legislators, that may still all be in the works for quite a while. And now I'd like to introduce our guest speakers from MACPAC. MACPAC is a nonpartisan legislative branch agency that provides policy and data analysis and makes recommendations to Congress, the Secretary of the U.S. Department of Health and Human Services, and the states on a wide array of issues affecting Medicaid and the state Children's Health Insurance Program. MACPAC serves as an independent source of information on Medicaid and CHIP publishing issue briefs and data reports throughout the year to support policy and analysis, program, and accountability. Martha Heberlein is a principal analyst at MACPAC. In her current role, Martha focuses on issues affecting Medicaid eligibility, federal financing, and implementation of the Affordable Care Act. Chris Park is also principal analyst at MACPAC, and Mr. Park focuses on issues related to managed care payment and Medicaid drug policy and provides data analysis using Medicaid administrative data. I'll turn it over to you.
So thank you all, and it's a pleasure to be here today. I'm going to see if I can get us to our slides. So I'm going to start our presentation today by providing some brief background regarding trends in Medicaid spending growth before providing an overview of some of the major alternative approaches to financing reforms which Rachel touched upon in her presentation, as well as highlighting some of the key design decisions for policymakers. And then I'll pass it off to Chris to provide some illustrative examples. So first, some context. Concerns about the level and rate of growth in federal Medicaid expenditures have prompted some federal policymakers to identify Medicaid's financing structure as a root cause of federal spending growth. However, it's important to note that the rate of growth in Medicaid spending reflects a number of factors. These include decisions made by federal and state policymakers about the size and scope of the program, as well as factors that are beyond their control, including population aging, changes in the economy, medical price inflation, and broader changes in the healthcare system. Increases in spending and service use also reflect the unique role that Medicaid plays in providing coverage to individuals without other sources of health insurance, including low-income families and high-cost, high-need populations such as people with disabilities and those in need of long-term supports and services. It's also important to note that the drivers of cost growth have implications for any alternative approach, including the amount of federal savings achieved and whether the alternatives include the mechanisms that will effectively slow these cost trends. So growth in aggregate Medicaid spending has led the program to account for an increasing share of both national health care spending and federal and state budgets. However, Medicaid's rate of growth in spending per enrollee has been comparable to or lower than that of Medicare and private insurance since the early 1990s. And its growth is projected to be lower than that of Medicare and private insurance going forward. The changes in Medicaid spending can be driven by changes in the number of people enrolled in the program, changes in average spending per enrollee, or both. The majority, or about 71%, of real Medicaid benefit spending, so adjusted for inflation, growth between fiscal year 1975 and fiscal year 2012 is attributable to growth in enrollment as opposed to growth in spending per enrollee. So while a factor, not all enrollment growth is driven by eligibility expansions. For example, population aging can increase Medicaid enrollment because low-income individuals become eligible for Medicaid when they turn 65. Decreases in income during economic recessions also increase enrollment under existing eligibility rules, particularly among children and adults. In addition, efforts to expand outreach and simplify the enrollment process can also increase take-up rates among the eligible population and increase enrollment. Changes in spending per enrollee accounted for about 30% of real growth during the same time period, and this growth is influenced by a number of factors, including changes in prices and payment rates, the breadth of covered services, the amount of beneficiary cost sharing, and the mix and composition of beneficiary populations. Okay, so moving on to the alternative financing proposals. With that as background, I'm going to talk briefly about three major proposals: block grants, capped allotments, and per capita caps. So starting with block grants. Block grants are structured to provide lump sum grants to states with amounts based on a predetermined formula. States would then spend the funds on a specified range of activities that could either be narrowly or broadly defined. Under a block grant approach, states typically do not need to provide matched funding, but may be subject to a maintenance of effort requirement on existing spending. A block grant approach would eliminate the automatic increases in federal funding in response to enrollment growth and the increases in per enrollee spending. A capped allotment acts as a ceiling with federal funds provided as matched payments up to that cap. Under a capped allotment approach, states are required to contribute state share to draw down federal matching funds from their state-specific allotment. They may receive less than the full amount of allotment in a given year, depending upon their level of spending, but are limited in the total amount of federal financing by the amount of their state allotment. This differs from a block grant, under which states receive the full grant amount without providing state match. And the State Children's Health Insurance Program, or CHIP, is funded as a capped allotment. Finally, a per capita cap would establish per enrollee limits on federal payments to a state, with federal spending rising based on the number of enrollees, but not on the cost per enrollee. States would be responsible for any spending above the fixed per capita amount. Unlike fixed block grants and capped allotments, the total amount of federal spending would vary with enrollment changes, and per capita caps could be designed on an aggregate level or on a more targeted basis, for example, by each eligibility group. So moving on to some of the design considerations. As I mentioned before, Chris will walk through some illustrative examples of how the different decisions on these design choices in his presentation, but I wanted to walk through them quickly just so you have a basis for what we're talking about. So there's several design considerations that policymakers would need to make when thinking about how to establish the spending limits. The first step they're likely to take would be to choose a base year to define the overall spending limit, and that would establish the overall cap in some cases, and also sort of what they're basing their calculations off of. Policymakers may also want to consider whether or how to increase spending going forward and choose a growth factor that reflects their policy goals. They also would need to determine how to allocate spending across the states, and depending upon the approach, how to establish per enrollee spending caps. There are also some additional design considerations to keep in mind. Given the size of state and local contributions to Medicaid, federal policymakers will need to clarify their expectations about continued state financing as the federal portion of the program is restructured. Policymakers must also weigh which aspects of the program will fall under the new approach and whether to exclude certain groups of enrollees or types of spending. Finally, under a restructured program, policymakers may wish to provide states with greater flexibility to manage their own programs in exchange for fewer federal dollars, but at the same time, they will also need to decide upon the appropriate level of federal oversight and accountability. Finally, while changes in Medicaid financing could be designed so that the future level of federal spending is higher or lower, block grants and per capita caps have typically been offered in the context of achieving substantial federal savings. So for example, the last 3 budget resolutions passed by the House all included federal savings for Medicaid ranging from $700 billion to $1 trillion over 10 years. I want to note that few details regarding how these savings would be achieved were included in the committee documents, but budget resolutions are generally broad statements of policy, and additional legislation that would flesh out these details was not introduced. So the examples Chris will present are based on prior approaches, but we also want to note that none of these received a score from the Congressional Budget Office, which is the official scorekeeper in D.C., so we don't know what their budgetary impact would be, including whether they would produce any federal savings and the magnitude of those savings. So with that, I'll pass it off to Chris. Sorry, wrong way.
Okay, thanks, Martha. So Martha went over some of the design elements to consider in any of these alternative financing proposals. I'm just going to walk through a few illustrative examples of how the choice of base year and growth factor may impact the spending caps. These examples do not reflect any specific policy details or bill language. So at a very high level, all the proposals to date choose a historical year of spending and apply a growth factor to establish the spending cap. The choice of the historical year of spending is important as it establishes that baseline for the spending cap, and there can be year-to-year fluctuation in spending and growth in spending. So this graph shows benefit spending in Medicaid for fiscal years 2011, 12, and 13, which it looks like the 3 got cut off on the last chart. And at least on my screen, some of the numbers don't appear. But so spending increased less than 1% from about $408 billion in 2011 to $409 billion in 2012, and then increases over 5% from 2012 to $433 billion in fiscal year 2013. Generally speaking, a year with higher spending should lead to a higher cap in the future, but that is not always the case. And so this graph shows an example of a block grant scenario using either the fiscal year 2011, 12, or 13 base year and trending that base year forward using the Consumer Price Index. The dark blue line at the top shows actual and projected benefit spending from the CMS Office of the Actuaries report. One thing to note here is that we excluded spending for the newly adult eligibles from fiscal year 2014 onward to keep the covered populations the same throughout this time frame. Under this example, fiscal year 2012, if you use 2012 as the base year, it's that dotted line at the very bottom, would lead to the lowest cap in spending in fiscal year 2017. This is because even though the actual spending was greater in fiscal year 2012 than it was in fiscal year 2011, the growth in spending between 2011 and 2012 was less than the CPI trend. In fiscal year 2013, which is the dashed line, would lead to the highest cap in spending. This next graph is similar to the one before, but it shows a per capita cap scenario. So spending per full year equivalent for each eligibility group is calculated for those base years and then trended forward based on the Consumer Price Index. And one thing to note is this one's a little different because of the way rounding works in calculating the per capita cap amounts and multiplying them out by the enrollees. Here you can see, similar to the block grant approach, fiscal year 2012, which is that dotted line at the bottom, still leads to the lowest cap in spending. However, the fiscal year 2011 and 2013 have changed places, with 2011 which is the light blue solid line, leading to a higher cap. And this is because the per capita cap approach takes into account enrollment growth. And so while total spending between 2011 and 2013 grew faster than CPI, spending per full year equivalent did not. And so these two graphs just show examples of how, even though a later base year may have higher spending, it may not always lead to a higher cap in the future. This next graph shows, it's pretty busy, but it shows the percent change in annual benefit spending from fiscal years 2009 to 2013 by state. And all the light gray lines represent individual states, and there are three particular things highlighted. The one in the middle, the dark blue line, is the national average. And you can see that, it doesn't show too much fluctuation year to year, but the green line, state A, and the light blue line, state B, you can see significant up and down movement between fiscal years 2011, 2012, and 2013. And so, for example, if you took 2012 as the base year, you can see how that would have a different effect for state A and state B. State A would have a lower base year spending than if 2011 or 2013 were chosen, and that's vice versa for state B. This next set of slides is just showing examples of the choice of growth factor. The growth factor could be linked to a number of measures such as price inflation, economic growth, or healthcare spending. And so for this particular graph, we used fiscal year 2013 as the base year spending and trended it forward to fiscal year 2023 using the actual and projected changes in consumer price index, gross domestic product, and national health expenditures to show the difference if you use different trend factors under a block grant scenario. Similar to prior examples, we excluded spending for the new adult group. One thing we did in this example is include administrative spending. And so here you can see that the CPI trend, which is the light blue line at the bottom, would lead to the lowest cap and thus the greatest reduction in spending by fiscal year 2023, followed by the GDP trend, which is the dashed green line. This next graph is very similar to the one before, but shows a per capita cap scenario. And similar to the chart before, the CPIU trend at the very bottom, the blue line, would still lead to the largest reduction in spending of the three trend factors. The GDP trend, which is the dashed green line, is very similar to what's projected by the CMS Office of the Actuary. And this table just summarizes the different trend scenarios I walked through in the prior two charts and compares the projected federal spending from the Office of the Actuary to the cumulative reduction in federal spending for each scenario over that Office of the Actuary projection for that 10-year period between 2011 and 2023. Here you can see the CPI trend under either a block grant or per capita cap scenario would lead to the greatest reduction in spending. Excluding the new adult group would reduce federal spending by about $633 billion over this time frame. So under this example, if coverage of the new adult group is repealed and spending is trended forward at CPI, there would be $1 trillion reduction in spending over this 10-year period using either a per capita cap or a block grant approach and trending it forward at the consumer price index. And it's just highlighted there, the two different scenarios. And so with that, I'll pass it along to the next set of presenters.
Okay, great. Thank you so much, Martha and Chris. We do have a question directly related, though, before we move on. A participant asks, wouldn't states be responsible for any spending above the capped amount on each of these three options?
Yeah. So I think yes, they would be, but in the the reason I sort of highlighted it in the per capita approach is that the spending is based on each individual. So if you spent more on a particular individual above that particular level, then you would be responsible for that amount. But the same would hold true in a block grant or a capped allotment, that if the state spent more money than they were given in federal funds, then they would be responsible for that spending.
Okay, great. Thank you. And we'll return for more question and answers soon. But I'd like to move on to the legislative respondent section of the webinar. We'd like to thank the Health and Human Services Committee at NCSL for sponsoring this webinar. The committee is responsible for protecting states' interests in federal decisions regarding Medicaid and the CHIP program, as well as a number of other programs that provide critically important services. The committee at NCSL provides our members with an opportunity to share and learn from each other and from other states in shaping health and human services policy and in addressing key health and human services issues in their states. So the committee has two legislator co-chairs, Representative Joni Jenkins from Kentucky and Representative David Heaton from Iowa. Representative Jenkins has been called away. I don't think she's on the line yet. She was hoping to join us late, but she's been called to the floor. So we also asked Representative Robin Gable to join us. She represents House District 18 in Illinois. She currently serves as a vice chair for the Appropriations and Human Services Committee as well as the Medicaid Subcommittee. So as part of our response, we'd really like to move on to you, Representative Heaton, if you would mind joining us to give an overview of the Senate Finance meeting that you attended last December.
Well, they talked about a lot of things besides Medicaid. They did talk that the new plan was on the front burner and that they'd be working for it, and they were quite confident that Verna would do a good job. As far as flexibility is concerned, they were referring us to an Orrin Hatch plan in 2013, and we visited a little bit about that. The block grants could risk. That was one thing they said. I mean, the block grants, I'm not talking about the Medicaid block grant concept. I'm talking about the other block grants are up and at risk, perhaps. We talked about substance abuse and told them that 15 days were not enough out of Medicaid. TANF, very upset about the states, what they were doing with their TANF dollars. They said that we were not using them as they were intended, and the ability to use that money for other than what it was originally to be used for will be eliminated or strongly discouraged. They were critical of our response to expansion of 4E, said that we were supposed to move away from group care to prevention, and they're not happy with the progress that we've had on that and want to see us do more. CHIP. State has been using leftover money in CHIP for other things in their budgets, and they're quite upset about that. We need to reinvest the leftovers back into CHIP rather than using it somewhere else. The SPBG block grant will have to be evidence-based, and that was about it. That was the majority Finance Committee that talked to us about that. So then we went to visit with the minority, and they're quite concerned. Talked about Tom Price's plan of taking $2.1 trillion out of Medicaid, $1 trillion coming from the elimination of the Medicaid expansion and eliminating and reducing Medicaid by 30%, gaining another $1.1 billion. And what we commented on was that if they give us flexibility, we don't care what they give us, we can't address that kind of reduction. Concerned about drug pricing, long-term care, 40% are on dual, 2 out of 3 nursing homes, and go on here, white paper, Hatch white paper, they refer to that too. The majority, now we just did conflicts. I mean, it looks like the plan is going to put more DISH dollars back in rather than and eliminating the reduction that came along with Obama. But they also say that the majority does not like IGTs. They don't like provider taxes. Those could be eliminated, or the ability to get them will be severely curtailed. And the minority party's worried about how generous the block grant's going to be. That was about it. But we came away from the 2 meetings very much concerned about how we will be able to operate under these new plans. Hello?
Hi, this is Rachel. I think we've had some technical difficulties. Some of our staff is offline now, but we can move forward to some questions, or is there anything else that you would like to comment on, Representative Heaton? Representative Heaton, can you hear me?
Yes, I can.
Okay, great. I said, is there anything else that you'd like to comment on before we move forward for the question?
I thought you were asking your audience. No, yeah. It's just that, after the report that we just had and then what I heard in Washington, D.C., I'm still confused about, especially, I just don't know how we're going to be able to, we have providers, let's put it this way, if we're locked into a block grant and we don't get any kind of inflation coming along with it, how are we going to be able to address the services that we are providing our people, but at the same time accept the fact that our providers are going to have reimbursement increases along the way so they can continue to operate and be able to pay the people out there who are delivering those services. That's bothering me.
Okay.
You can put us on a diet, but I can't sit there and put my providers on the diet and not have a workforce there to do what we're supposed to do.
Right. We did have one question concerning CHIP that someone typed in the system, that asking the enhanced CHIP rate that was included in the ACA, and that it hasn't gotten much attention in reports around the ACA repeal and replace, and asking what seems likely to happen to that enhanced rate. And when we had the meeting in December with Senate Finance staff, they did have to mention this, and it didn't sound positive, quite frankly, that would be moving forward. And I agree with you, we have not heard an awful lot about it since, but that's the feedback that we had gotten in December, was that the enhanced CHIP rate would not be there for you. So, and the CHIP funding, something will have to be done with it legislatively to continue, because the funding ends the end of September as it is currently. However, the states would be required to continue their programs for another 2 years beyond that. So we need to keep track of what's going on in Congress to make sure that that funding continues. We unfortunately looks like we may have lost Representative Gable. Representative Gable, are you there? I think she lost her audio. we'll move forward with, there was another question concerning CPI and so on. But I'll just read that, and this is for Martha and Chris, I believe. Did the projections use straight CPI, CPIU, or CPIU medical as the inflationary CPI factor? Martha and Chris?
Yeah, this is Chris. The examples use CPIU as the inflationary factor.
Okay. Let me see if we...
Hi, Rachel. This is Lisa Waugh again from NCSL, and thanks,
Good.
everybody. It seems like we're having some technical difficulties trying to get Representative Gable on the line, but we do have a couple of other questions we can turn to. The enhanced CHIP rate, this is for Martha, the enhanced CHIP rate that was included in the ACA has not gotten much attention in reports around ACA repeal and replace. What seems likely to happen to that enhanced rate?
Well, Rachel already talked about that a little bit when you guys were having your technical difficulties, and I agree with her. It hasn't gotten much attention. It did in the speaker's plan last year that he released the Better Way plan, which a lot of the more recent discussion has focused on, did roll back the 23 percentage point increase that was part of the ACA, but it has not appeared in the more recent versions of things that we've seen.
It looked like when we visited the Senate Finance Committee and the majority, they were so upset about the money, extra money being used elsewhere besides the CHIP program that, you know, perhaps they feel we can do without the 23% and refocus our efforts on children only.
Representative Gable, are you trying to speak? Okay. We do have another comment here. I'm not in response to Representative Heaton. I'm not sure if this is a question, but in response to Mr. Heaton's comments, I find it interesting that there was a discussion about all of the concerns regarding how states are using existing block grants, followed immediately by a discussion of how block grants would provide states with more Medicaid flexibility. It seems to me like the flexibility is often not as flexible as advertised. Do you have any comments on that?
No, I was really surprised to hear him talk about the block grants that way. I didn't really. I guess we didn't really say, well, what do you have in mind, or what's the criticism about this? And I can't remember a response. I don't remember us carrying the conversation any further. I mean, the lady who's been with the committee for a long, long time had some very strong opinions and pretty much told us what, gave us a straight skinny on what she expected out of us.
Hello?
Yeah?
Hello?
Hi, it's Robin Gable. I got back in.
Okay.
Do you want me to give my update on Illinois?
Yes, please, thank you. I'm sorry you had some trouble calling.
No, I didn't realize I should have stayed in the other, where I was the only conferencee. Anyway. So Illinois is in similar shape to Iowa. If we go to any of these scenarios, we will lose significant dollars. I mean, we have right now 645,000 people are covered under the expanded Medicaid. So to try to find an alternative for them would again be very difficult. And we have quite a few people in the marketplace. Now, is that going to stay? I wasn't sure from hearing the talks if that was going to stay or not. It sounded like we were going to go back down to base Medicaid that we had before the Affordable Care Act. So, Illinois is over 10 years, we would lose $49.9 billion in funding. So one of the things that our governor is doing to help prepare for this is is trying to get everybody, all the clients, patients in Medicaid, into managed care. He just put out a new RFP to reduce. We have many MCOs in Illinois, like 12 or 13, and he's going to reduce that to 5 to 7. I'm not sure exactly how that's going to cut costs, but that's the plan. And right now we have 60% of our people in managed care, and this proposal will put 80% of people in managed care. So that's kind of what's going on in Illinois in a nutshell.
Well, here's what we got going in Iowa. I contacted the department and had them give me a short briefing, and they are preparing to get themselves ready for what's coming. My director of Human Services thinks that this will fall into place in 2020. There'll be a transition period, and then it could be here in 2020. We're shifting from fee-to-service to value-based in our Medicaid and in fact, our whole healthcare system. We've been working with our funders, Medicaid, Medicare, and commercial to move from the fee-for-service to value outcome-based system of service. And what we've done is through our SIM grant, and now we were applying for our 3rd and 4th year, we are creating a vertical integrated health system using ACO approach, and those ACOs will connect with our managed care organizations so that there's a total vertical approach. And we're conducting now roundtables with all of the providers, behavioral, medical, Medicare, all of them around the table, and they're starting to work and collaborate together in determining exactly how we will address what's going to come and the changes that we have coming. So that's about it with us anyway.
Thank you, and we do have a question here for you, Representative Heaton. In your meetings in December, did you meet with staff from House Ways and Means or Energy and Commerce, and did they have the same concerns about how states are using these dollars? The Senate and House staff frequently have different views.
Yeah, the minority party didn't really talk about that, except that they did tell us that they commented that said that the majority did not like DISH, but we know that can't be true because they're going to increase the DISH. But they didn't like IGTs and they didn't like provider taxes. That was their comment on the majority. And they just perceive the squeeze and are very concerned about that.
Lisa, this is Rachel. I can actually make a little comment on the House staff. I did have a chance to meet briefly with staff members from both committees with the majority, and the predominant thing they wanted to discuss was crafting some new waiver possibilities. We didn't get into details about other programs. It was primarily looking at moving forward how they might want to ease the waiver process for states and looking at their capability of, I would believe, doing things differently in a transition. We did extend invitations to staff from Energy and Commerce. It's a very difficult time right now to gain their participation in things like this because they are extremely busy. There's a lot going on the Hill right now. And I also extended an invitation to Senate staff as well, but they were unable to accept at this point in time. But we do hope that in the future we'll be able to gain their participation in other webinars, as there's actually language that we're going to be able to look at and ask questions about as they move forward with it.
Rachel, when they talked about the waivers, of course, that means flexibility. Did they talk about really how much flexibility they figure they're going to allow us to have in administrating Medicaid within our states, how much freedom are we going to have, and what do you think some of the things are there that we could do?
It was really the discussion really was more in relation to just easing that process and streamlining it so that the states would be able to take action quicker, not the actual substance of what the waiver would say and the flexibility within the waiver. So that is a point of discussion we need to have with them to find out what they're thinking, and we'll be doing that as much as we can.
Okay.
Okay, great. Well, we have we appreciate all the questions. We have probably run out of time, and so thank you to all of our speakers, and thanks again to the Health Committee at the National Conference of State Legislatures. This webinar has been recorded and will be made available on the NCSL website, and please feel free to follow up with either Rachel or I if you have any other questions we can help you with. Our emails are listed here, and stay tuned because we hope to have a series of webinars available to you in the next few months to help states manage upcoming proposals. So thank you for joining us, and goodbye.
Thank you.
Thank you. This does conclude today's webinar. We thank you for your participation. You may disconnect your lines at this time, and have a great day.